Services, New York City, and he is also Executive Vice Chair, Department of Pediatrics in the United States. He is going to talk to us about healthcare-associated infection in the NICU. Welcome, Professor Richard.
Thank you. Let me just pull up my slides. All right, is that clear to everybody?
Yes.
Well, thank you. So I really appreciate the invitation to speak to Saudi Arabia today. I was there in person a few years ago, and I hope to get back to you in person. But this is the next best possibility. I'm going to be speaking about one of my favorite topics in neonatology. Start with a little history. And it's one of my heroes in the NICU, and it's Dr. Semmelweis. I'm sure some of you know the name, who practiced in the 1800s. So Dr. Semmelweis was a young obstetrician who practiced in the main maternity hospital in Vienna. And at that hospital, they were seeing a major discrepancy between maternal mortality in their hospital, which is the red line here, compared with a hospital in Dublin. The event which preceded all that was the beginning of anatomic pathology, or at least the Department of Anatomic Pathology. And I'll show you in a moment why that was very important. So Dr. Semmelweis arrived somewhere in the 1830s, and he saw this discrepancy. And about that time, they separated the midwives who were delivering women from the physician, from the obstetricians who were delivering women. And one thing that the physicians did, the women did not do, is that when a woman died in childbirth, the physicians would go down to the pathology room for the autopsy. And you can see here, they were doing the autopsy, not using any gloves. So they would then go back up to the maternity ward and do pelvic examinations of women in labor. They did not believe the midwives needed this kind of practical instruction. So the midwives had only classroom instruction. So Semmelweis said to himself, there must be something that's transmitting those death-dealing cadaverous poisons from the from the vagina of women in childbirth to the women, subsequent women in their delivery suite. So Semmelweis, this is obviously a recreation, made all the obstetricians soak their hands in a fluoridated lime solution, obviously not using gloves. But when he did that, the risk of puerperal fever or these healthcare infections epilepsy, central line associated bloodstream infections, the most common kind of infection we see in the NICU. And lastly, we were talking about predictive monitoring, how we can identify babies who are likely to become infected and provide you with some conclusions. So why do we worry about these infections? I like to say they're the 3 M's: money, mortality, and mental deficiency. So these data are now about 9 or 10 years old, but in the United States, healthcare-associated infections were causing about 100,000 deaths and costing about $6.5 billion. And I can easily guess that the estimate around the world is in the trillions of dollars. The Center for Medicare and Medicaid Services in the U.S. will no longer reimburse a hospital if that individual has a catheter-related bloodstream infection. They view that as a never event, sort of like falling out of bed. A patient should never fall out of bed. A patient should never have one of these kinds of infections. In the NICU, data from the Neonatal Research Network says that these infections are responsible for just slightly less than half the deaths after 2 weeks of age. We know that they're associated with poor neurodevelopmental outcome, and unfortunately, they are common events in the NICU. And these are data both from the United States and from a group internationally. The data from the United States is broken down to different birth weight categories. You can see from less than 750 to greater than 2,500 grams. These are central line associated bloodstream infections. And the data were comprised as of 2013. In the parentheses are data from an international collaboration, the International Nosocomial Infection Control Consortium, of which Saudi Arabia, or at least some hospitals in Saudi Arabia, are part. And there are a couple of things that are striking. One is that how much higher the data are from INIC, and to be fair, they come from some hospitals in developed countries and some hospitals in less developed countries, but they are substantially higher in the INIC database. And you ask yourself, why is that? There's not a marked difference in the incidence of immunodeficiency in those countries. And I'm going to try to make the argument that the increased incidence in the INIC hospitals in their level 3 NICUs is probably due to poor compliance with hygiene. And I mentioned that these kinds of infections are costly in terms of dollars. And this study now is about 9 or 10 years old, and it looks at the costs of hospitalization of babies that have nosocomial infections. On this graph here, babies with nosocomial infections or healthcare associated infections are shown yellow. Babies with no infection is shown blue. And on the x-axis are different birth weight categories from 401 to 750, last category being 1251 and 1500. The two sets of bars at each birth weight category are representative of observed data and secondly adjusted for confounding variables. But it's pretty easy to see that babies with infections are more costly in each birth weight range or each birth weight category. On the table at the upper right part of the slide, it's broken down again into different birth weight categories and the costs of hospitalization without a bloodstream infection versus a nosocomial or bloodstream infection is shown in this table. And for each category, it's about $30,000 difference. So having one of these infections greatly increases the cost of hospitalization. And the bottom part of the slide, the bottom right, looks at various pathogens. Again, here's no bloodstream infection. The mean cost is about $50,000. Coagulase negative staphylococci, double that. Other bacteria, such as Staphylococcus aureus and gram-negatives, increasing them further. And the most serious and most costly kind of infections are fungi. And I mentioned that babies who are experiencing infections are at greater risk of adverse neurodevelopmental outcomes. There have been a number of papers on this topic. This, I think, is the largest study. It comes from the Neonatal Research Network in the United States. And it's looking at 4 outcomes: mental development index less than 70, MDI, psychomotor developmental index less than 70, PDI, cerebral palsy and microcephaly. And for almost all of these outcomes over here, for almost all of these outcomes, the rate of MDI less than 70, PDI less than 70, CP, and microcephaly is significantly increased. So let's talk about the most common kind of infection we see in the NICU. These are CLABSIs, or central line associated bloodstream infections. And this represents 5 databases from across the world looking at the pathogens responsible for these kinds of infections. And for the most part, they're pretty similar, at least if you look at the first 4 studies, showing that coagulase negative staphylococci are the most common infections, followed by gram-negative enterics, followed by other gram-positives. The last study from Yale is an outlier. And you can see here the number is significantly down. I'd like to show you this study in a little more detail. In that study by Matt Pizarro, they looked at 3 time periods, 89 to 2003, 2004 to 2009, and 2010 to 2013. And you can see in the last time period, they exhibit a significant decline in coagulase negative staphylococcal infections. I'll show you that in the graph in a moment. On the other hand, gram-negative infections increased significantly. Here's a graph I promise you. One of the observed data and the red line is smoothed out data, but they exhibited this dramatic decrease in coagulase negative staphylococcal infection for 2 reasons. First of all, they began using bundles groups of interventions to lessen the incidence of collapses in the NICU. And secondly, they began to stop doing central line blood cultures in the babies. If they were worried about a baby with a potential central line infection, they took 2 peripheral vein blood cultures. So I think it's important. It's an important concept. And the way I interpret blood cultures for coagulase negative staphylococci in a symptomatic baby, what do I recommend? I recommend 2 peripheral vein blood cultures and starting broad spectrum antibiotics. You'll see in a moment that we begin in our unit oxyphil and gentamicin. Other units use vancomycin, gentamicin. If both cultures are negative, obviously the baby's not infected. If only one culture is positive for coagulase negative staphylococcus, we say that's presumed contamination. And if both cultures are positive, it's true coagulase negative staphylococcal bacteria. But we do not anymore do central line blood cultures. If we look at a list of the risk factors for these kinds of infections in VLBW babies, and this is a composite of many studies done around the world, obviously the strongest correlation with birth weight and gestational age. Tinier babies have an increased risk of immunodeficiencies, and in addition, they have the most greater likelihood of invasive monitoring, even things like heel sticks. Parental alimentation and central lines, obviously a risk factor. Intralipids probably, or fatty emulsions, are probably an independent risk factor. 2 drugs we should worry about: steroids for BPD, associated with increased risk of central line associated bloodstream infections. Histamine blockers and proton pump inhibitors have both been associated with these kinds of infections. And more of a research tool is that babies who have a low serum IgG, that physiologic hypogammaglobulinemia that all premature babies have, the lower the value, the greater the risk of infection. Syndrome babies who need prolonged mechanical ventilation have a high risk of infections. Overcrowding and heavy workloads are both risk factors. And some people have said that staffing problems and inexperienced nurses is a major issue. But I'm not sure that is the case. This is a survey study from the United Kingdom. I think there were about 85 NICUs in this survey. And they looked at a number of variables for what they call nosocomial bacteremia. We would call them catheter-associated bloodstream infections. So as you might imagine, patient volume in the units with the highest patient volume, they had a greater risk of nosocomial bacteremia. They probably took care of sicker babies. The number of consultants was associated with a higher risk of central line associated bloodstream infections. Interestingly, nursing was not. So nursing provision, which is one of the theories put forward, was not associated with the risk of central line associated bloodstream infections. Why should consultants be associated with it? I'm going to make the argument that physicians are very poor at hand hygiene, which brings me to the topic of preventing these kinds of infections. So before we talk about prevention, we have to have a case definition for a central line associated bloodstream infection. And the CDC and World Health use this definition. It should be a recognized pathogen from at least 1 or more blood culture bottles not related to infection at another site. So Staphylococcus aureus, E. coli, fungus are all recognized pathogens. Or it can be a common skin contaminant. Here they require at least 2 or more cultures not related to infection at another site. And they point out that many of these babies have other systemic signs of infection. These are the guidelines for hand hygiene the World Health Organization has put forward. These are the ones we use in our own NICU. And some of them are pretty obvious. So before you touch the patient, obviously hand hygiene is important. Before you're doing a sterile procedure, after touching the patient, equally important. After a body fluid exposure, so if you come in contact with saliva or blood, it's important to do hand hygiene. But the one that is not followed as well as it should be in my own NICU is after touching the infant surroundings. So when we make rounds in our NICU, they commonly last about 2 to 2.5 hours. And after about the second hour, everybody gets tired, and before long, one of the residents is sort of leaning on a nice left. And I make sure that they use hand hygiene at that moment, because the bacteria that are in the environment are the same bacteria that are on the baby's skin and mucous membranes. So hand hygiene is very important if you're just touching the environment. Why does hand hygiene work? Well, remember there are two kinds of flora. There are flora that people call resident bacteria that live very deeply in the skin, represented by these little bacteria next to a tent. And then there are some people called transient bacteria, which live very superficially superficially on the baby's skin. Most of these infections are caused by the transient flora. Again, they're located very superficially. And degerming techniques, hand hygiene, are very effective in getting rid of the transient bacteria. Probably don't affect the resident bacteria very much. So the next couple of slides, I'm going to show you some of the recommendations. And after each recommendation, you're going to see a parentheses with a number and a letter. And the number indicates the strength of the recommendation, and the letter indicates the strength of the data supporting that recommendation. So using alcohol-based hand rubs, we use Purell in my nursery, but there are many alcohol-based rubs throughout the world. That's a 1A recommendation. If your hands are dirty or contaminated with blood or other body fluid, they're recommended to wash them with a non-antimicrobial soap and water, which is what we recommend, or an antimicrobial soap and water. The reason I don't like antimicrobial soap and water is they can damage the skin. So that's a level 2 recommendation. And any anionic soap or detergent can leave the skin quite red and damaged. And remember, damaged skin harbors more bacteria. Although our colleagues in surgery still use brushes, they're no longer recommended in the NICU. That's a 1B recommendation. Do not use artificial nails or extenders. When I first came to Columbia back in the early part of the last decade, we had an epidemic of Pseudomonas clapses in my NICU, which we traced to a nurse who had artificial nails. And when those artificial nails were removed, the epidemic subsided. And that was reported in New England Journal of Medicine. So keep the nails short, no dark nail polishes. Clear nail polish is acceptable because at that point you can see the artificial nails or extenders. It's important to wear gloves when you're coming into contact with blood or other infectious material, mucous membranes or non-intact skin. That's a 1C recommendation. Hand washing material should be really at the site of the infant in the NICU. It's a 1B recommendation. And also very important, I think it's had an effect in my own NICU, is monitoring the hygiene practices of healthcare workers. So I hope some of you, and I'm guessing it's true, have secret observers in your NICUs. This is a secret observer in our NICU. It's actually a medical student who comes onto the floor each morning and with this little iPad or phone and watches how people interact with babies. Do they use hand hygiene before and after examining each baby? And they send this report to the chief of neonatology so we can go back to the practitioner and say, by the way, you did not use good hand hygiene. But just knowing that this kind of individual, a secret observer exists, is a great motivation for all healthcare workers to use good hand hygiene. These are practices to prevent these kinds of infections. Obviously, hand hygiene, sterile gloves, when you're inserting a central line, maximal barrier sterile dressings. We use chlorhexidine. It's a combination we use chlorhexidine plus alcohol, a preparation called ChlorPrep for insertion of central lines. We use povidone iodine for insertion of UA or UV catheters. We try to select catheters in the upper extremity versus lower extremity. In adults, that may make a difference. I'm not sure it does in the NICU. And this is important. We ask ourselves, is the central line necessary for a newborn baby? Our feeding is going to be advanced enough so we can discontinue the central line. When we access the central line, again, we're using good hand hygiene, maintaining good aseptic technique. We date our tubing because sometimes tubing needs to be changed based on what's being infused through it. And this is important. We scrub the hub with chlorhexidine or alcohol for 15 seconds because most central line infections in newborn babies happen from a contaminated catheter hub, and it goes along in the inside of the catheter and finally into the bloodstream of the baby. So to decrease the catheter hub colonization and to decrease central line infections, we scrub the hub for 15 seconds. Do they work? Well, I can only show you data through 2012 for my NICU. And these are looking at babies of various birth weight categories. They do work. I can tell you that we narrow the antibiotic coverage once the pathogen is identified and the sensitivity are known. Infections due to coagulase negative staphylococci, proven infections, are treated for 7 days, Staphylococcus aureus for 14 days, and gram-negative bacteria for 7 to 10 days. And we do a lumbar puncture for any positive blood culture other than coagulase negative staphylococci to rule out meningitis. So my conclusion for this part of the lecture is to avoid care practices which bypass skin barrier defense mechanisms, avoiding central lines, UAUV catheters, EL sticks, limit the use of drugs which increase the risk of infections. I mentioned steroids for BPD, H2 blockers, and proton pump inhibitors. If you have a baby that's colonized with a resistant or invasive pathogen, try to cohort those babies and always use gown and gloves. Limit the use of antibiotics, and we need to use the simplest and most appropriate drug, in other words, antibiotic stewardship. The alcohol-based emollients improve compliance, and I think that is worthwhile. Try not to scrub your hands with brushes, avoiding skin damage. Breastfeeding is important. Minimizing central venous catheter days and sterile barriers for central line insertion and line maintenance. And for the last part, I'd like to talk about diagnosing these infections. So, in any baby with suspected infection, do a physical. You may get a blood culture. If it's a late onset infection, we think about urine culture. In selected babies, we do a CSF culture. Commonly, we get a white blood count and differential count. Some of you probably measure C-reactive protein or procalcitonin, which are acute phase reactants. Now, for many years, people have talked about interleukin-6 as a great test to pick up infection in babies. And this is a study now, it's about 15 years old, but there are a number of studies like it showing that IL-6 goes up very quickly with proven sepsis in babies versus antagonists shown in red here, IL-6 shown in the blue dotted line, and C-reactive protein. Here we have the days preceding infection, and you see here that CR1 of the cytokine. Well, in our NICU, we all measure, I'm sure you do too, heart rate, respiratory rate, saturation, and blood pressure. And just looking individually at those, they're pretty late markers of cardiopulmonary compromise. And baby has a bradycardia or hypertension, we know something is wrong. But in the past 5 or 10 years, there's been an interest in predictive monitoring or analyzing waveforms to predict an event which is going to happen. Now, organs constantly cross-talk to one another along anatomic, neural, and endocrine channels. In healthy individuals, this kind of crosstalk results in variability of heart rate, in the respiratory rate, blood pressure, saturation, temperature. And if you look at it from the outside, there appears to be no relationship between those variables, and the data looks very chaotic. But during a disease process that acts as a stressor for the baby, communication to the organs, and consequently variability in organ system readout decreases or ceases altogether. In other words, there's a loss of variability, and the term applied to that is decomplexification. It signals pathology in a potentially catastrophic event. And there's a way to measure that. There's actually a commercial device which is present in the US, and I don't know about the Middle East, it can be found in Europe, and that's using the HERO monitor. The HERO monitor looks at three variables derived from the RR interval: the standard deviation, what's called sample entropy, which is a measure of irregularity of the heart rate, and sample asymmetry detects deceleration. But when there's an infection, a signal is sent back to the brain, and then via the vagus and autonomic nervous system, there are effects on heart rate variability and on heart rate decelerations. So this is a healthy baby. The HERO score is very low. The heart rate goes up and down, and there's a lot of variable. We see no marked acceleration. This is a baby who has had an impending infection. You see here that the variability compared with up here of the heart rate goes down significantly. And there's these very brief decelerations. In fact, they're so brief that they would be impossible to detect on a monitor. But using the HERO algorithm, they can be detected. And in this baby, who was developing a gram-negative infection, the HERO score went up. It became 4.29 versus 0.21 5 days ago, telling us we ought to examine that baby very closely. It does not tell us the baby has an infection, but it tells us the baby is getting sicker. And it's proven to be a highly useful tool for early detection of sepsis. Recently, there's been a new tool that's now being investigated by faculty at my institution, Rakesh Sani, Joseph Eisler, Phil Grave, and investigators at the University of Virginia. And that's looking at the correlation between heart rate and saturation. Now remember, I said that there's a decomplexification, and we're looking here for a better correlation between heart rate and saturation. So this is what from a baby in our NICU, 9 hours prior to delivery of E. coli sepsis. Here's the heart rate. Here's the saturation. You can see these curves are, one is a mirror of the other. In fact, the respiratory rate is following a very similar pattern. And we've now looked at a number of babies. We have a new NIH grant to study this. The relative risk of late onset sepsis, nephrotoxic enterocolitis in the next 24 hours, when the poor correlation is very low. However, as that correlation increases, the risk goes up significantly. Here's my final slide. Healthcare infections are an immense problem in your country, the Middle East, Europe, and the United States and South America. They increase mortality and morbidity. They have added trillions of dollars to the quest of acute care. And I think that predictive algorithms based on measuring physiological variables may provide an early warning for these before the baby becomes clinically symptomatic. Thank you very much.
Thanks, Prof. Paulin, for a nice presentation. Now we will move for the third lecture by Dr. Daniele Di Loca.